right. Welcome to my EMCCM talk. If if you guys don't know me, my name is Xiao, PGY4 EM. Special shout out to the EMCCM team, Dr. Aries and Dr. D'Souza. So the EMS history for this patient, 66-year-old gentleman coming in for trouble breathing for 3 days, can't speak in full sentences, extremely anxious appearing, wheezing bilaterally. 3 lead just shows sinus tach. Here are his vitals. He is tachycardic. He is hypertensive, tachypnic. They didn't take a temperature. He was hypoxic on room air. Still a little bit hypoxic on non-rebreather, but at 100% on CPAP. They started him on CPAP. They gave him 2 nebs and sub-Q epi because of the dyspnea. Gave him Dex 12 milligrams. I believe this was IM. Reportedly feeling better with the EMS interventions per the ACR. So he comes into the trauma bay in CCT. His airway is intact. He is tripoding tachypnic with retractions. This gentleman is working. He is tachycardic and he's fairly agitated, probably secondary to his dyspnea. Here are his triage vitals. He is more tachy. His blood pressure is suspiciously exactly the same. He is more tachypnic, he low-grade temperature, and he is sitting at 88% while still on the EMS CPAP. So because this is an EMCCM talk, we are going to have a little audience participation. So if one of the juniors can give me a preliminary problem list, not a differential, just problem list. You can go for Carl.
Start with this day was 2 years before he was starting on the CPAP, probably crashing. His respiratory rate is double, like almost more than double, 46. 46 is a lot. That means like 2 minutes crash, respiratory failure situation. He's also hypertensive to a 190. I guess like some epi stress, lots of chemical means in him. Yeah, I think like it's a B problem right now.
Yeah, no, that's pretty spot on. The only other thing that I would add on is that this guy was febrile. So the initial immediate interventions, what would you guys do, Caleb? Okay. So what would you do? Medications? What's up? Okay. Anything else?
Get max the BiPAP settings.
Okay.
So everything that like increase ECAP by 50, 100%.
Okay. Anything else? Would you guys do anything bedside? Sure. Sure. So I like all those suggestions. What actually happened, what the team did was they continued CPAP, but they got him on our respiratory therapist CPAP. They gave him an additional albuterol neb or duo neb, IV access EKG, and bedside sono. So here's the provider's actual HPI. The patient has a history of hypertension, alcohol use disorder, had trouble breathing for 5 days, can't speak in full sentences, has right-sided facial swelling and changes in speech, otherwise denied fevers, chills, chest pain, and belly pain. This is his past medical history, no allergies, no PCP, no history of asthma or COPD, and not on any medications. So his physical exam, right, we want to actually listen to his lungs. So he is alert, but he's in severe respiratory distress. He is anxious. He has moist mucous membranes. He has right-sided facial swelling with right-sided neck swelling, as well as tenderness to palpation. Tachycardic, he has tachypnic with accessory muscle use. He's got diffuse rhonchi. Belly soft, non-tender. He has no edema in the lower extremities, and he is alert. Here's his EKG. There was no comments from the primary team on what this showed. On my read, this looks like there's a lot of artifact, but it is sinus tach at approximately a little bit faster than 150 beats per minute, left axis deviation, and LVH. Ventitisano that was not documented in QPath. It just showed quote no B lines. That was it. Here's a portable chest X-ray that was done. There was no wet read by the primary team, but radiologist read showed it to be otherwise unremarkable. No consolidation, no effusion. Differential. Can we have Sam Evans?
So his face is swollen.
Correct. Neck.
Angioedema, anaphylaxis, some sort of like head and neck abscess. Doesn't sound like it's pulmonary edema, escape type picture. PE is still in there, although I don't know why his face would be swollen. Maybe that's just a red herring. No pneumothorax. No pneumonia, that's what I got.
Good.
Yeah, go back to the X-ray. It's like that. It's not the airway very narrow or something. No. Okay. Like here.
Possibly. You don't know if this was taken during inspiration or expiration.
Right.
So hard to say. It's just one view. So the differential, I agree with Sam. So deep neck space infection, including an abscess, is definitely way up there. Epiglottitis, bronchospasm, still on there, as well as PE, right? So on the initial reassessment, the patient reported subjective improvement, but he could not be taken off the BiPAP or the CPAP at all. His repeat vitals, he is still tachycardic. He is still hypertensive. His rest rate has improved a little bit. Fever's come down, and he is statting much better. So, any further tests and consultations? Can we have Raj?
Look at it based on that. We've got carrier airway that looks like there's infection or inflammation that we're calling in.
Sure. Did you say any labs?
Are you allowed in case you need some further procedures? As well as like plugging the right now, I also definitely want I mean, it seems like this is respiratory stress. It's not like a problem. We're like lean down. Yeah, I would do on the half really. So I just want to see like how you look like that.
Sure. So the primary team agreed with you. They got all these labs. They got the chest X-ray like we already saw, but they also had it on a CT soft tissue neck with IV contrast, as well as called ENT. Okay, but this was not until a little bit later, until after the CT soft tissue. So at this point, the patient got an additional dose of Duonebs, and they started the patient on a liter of normal saline. So you start to get some labs back, and you get a VBG. Can we have Herod interpret this for us?
Lactate, we did get a bunch of labs, so that's also almost like I think it's slightly elevated on
Sure. So first of all, you said this was an acidosis, correct?
Yeah.
So just for the juniors, so the medical students, so the pH is low. That's how we know it's an acidosis, right? Next up, how do we tell if it's a metabolic or a respiratory acidosis? Correct. Correct. Yeah. So if the CO2 were high, but the bicarb is high or normal, then that would be, or if the CO2 was low and the bicarb is not high or normal, then that would be a metabolic acidosis. But then since here the CO2 is high, then it's respiratory. When we have a respiratory acidosis, the next question that we should be asking is acute or chronic. What we look at is the bicarb. So, or the PCO2. So for every 10 units of increase in PCO2 above 40, bicarb goes up by 1 for acute, bicarb goes up by 4 for chronic. So in this case, the PCO2 is 20 above 40. So we would expect bicarb to go up by 2. So that would mean that the expected bicarb should actually be within normal range. Because the bicarb here is low, what we actually have is a mixed acute respiratory acidosis with metabolic acidosis. So just yep. So the CBC came back, patient has a white count, otherwise unremarkable. Pro BNP came back elevated with the negative trope, but that's neither here nor there. So next, the patient got blood cultures, 2 grams of mag, and additional NS bolus. And then we start to get the CAT scan back. So I'm just going to go through this semi-slowly. No. You guys saw it? Right? Okay. All right. Okay. So as soon as the CT popped up, then the primary team then gave 3 grams of unison right away. And then they got a prelim and a final read pretty quickly after it was done. So it's gas and fluid collection within the right parietal space, extending inferiorly, extensive edema with severe narrowing of the airway. So updated problem list at this point, acute respiratory insufficiency with a deep neck space infection, as well as sepsis, right? He had a white count, he had abnormal vitals, he had a fever. So they called ENT. ENT came and did a scope pretty quickly again, and they found that the epiglottis was omega shaped with an edematous airway. Could not see the glottis or subglottis, and the patient was not amenable to transoral intubation. Now, what is an omega shaped epiglottis? It is this. It is from inflammatory response causing significant edema and distortion of the epiglottic tissue. If they tell you they see this, that is bad. All right. This was in their consult note. They said neck fash with edema, high risk for airway compromise, plan for nasotracheal intubation with a possible conversion to a trach and IND in the OR. Okay. Patient went up to the OR as a level 1 case for an awake trach. As soon as the patient had induction of anesthesia, they coded for about 4 minutes. They got ROSC after a few minutes. They had a washout. They got started on pressors and admitted to the SICU. During the washout, they found murky purulent fluid. It was not described as dishwasher, but they found devitalized fascia and small branches of the internal jugular vein with thrombosis. So what is our final diagnosis? Yeah. So neck fash with obstruction and Lemierre's. So the next part of this talk is going to be just an overview of deep neck space infections, as well as for those difficult airways, this question of does using a bougie improve first pass success? Hopefully, if you have a patient who has severe airway obstruction like this, you can get them up to the OR in a timely manner. But if you have to intubate, then hopefully you have another tool at your disposal. So deep neck space infections. So we're going to start with just general presenting features because they all kind of have very similar defining features. So one of the first things is trismus. Can they open their mouth? If they can't, right, you should consider that they may have a deep neck space infection. A lot of times they may have induration and swelling below the angle of the mandible. This is Ludwig's in both these patients. You can have medial bulging of the pharyngeal wall. If you get a lateral x-ray and you see this, you should consider an extra pair of pants. And sometimes they have systemic toxicity with fever and rigors, right? You should always remember that this can be a difficult airway. So for my Lord of the Rings fans, this is to call ENT. This is otherwise known as an ENT for people who don't watch Lord of the Rings. And always consider nasotracheal intubations. We do not have nasotracheal tubes, but if you go somewhere that does, then you may be the one doing this. Otherwise, again, call ENT. They may tell you consider fiber optic intubation or an awake intubation. And the last resort is a surgical airway. This screenshot was actually taken from an MRAP video for a patient who had a cardiac arrest, but this was done in the setting of him having a jaw fracture 2 weeks prior. It was a little bit too gory for this lecture, but you can find it on YouTube on MRAP. So always consider intubation in the OR. Make sure these patients are stable until they go up there. So treatment. Generally speaking, a lot of times it's going to be for these infections, it can be drainage in the OR, but most importantly, you also want to give IV antibiotics to cover broadly, right? You always want to cover for usual staph, including MRSA, strep, and anaerobes that include Fusobacterium necrophorum, H. flu, Bacteroides, and Peptostreptococcus. But a lot of times it's polymicrobial, so just go broad. The first type of deep neck space infection we're going to be talking about specifically is the parapharyngeal space infection. Now, what is that and where is that? So we can see here, this is a cross-section of the skull. The parapharyngeal space is the green, kind of in the middle there. What I want you guys to kind of appreciate here is how close it is and how much it communicates with a lot of different spaces in the head and neck, okay? Including the retropharyngeal space and the carotid space. The parapharyngeal space is an anatomic space comprised of an inverted pyramid lateral to peritonsillar space and the nasopharyngeal cavity. Like I said, it does communicate with many nearby spaces. This is a cross-section, and you can see, again, all the other spaces that it communicates with. The issue is that signs and symptoms of a parapharyngeal infection can be a little bit difficult because it can otherwise be masked by the primary source of infection, whether that be most commonly is dental, followed by peritonsillar abscess, followed by parotitis, otitis, or mastoiditis, okay? Next up, we'll talk about retropharyngeal abscesses. And again, I bring back the same image. The retropharyngeal space is now the sliver of pink/purple, depending on what your monitor color shows. Typically, this is caused by, this is anterior to the prevertebral fascia, extends from the base of the skull to the tracheal bifurcation. And typically, this is caused by polymicrobial. This was one of my favorite shows growing up. I don't know if you guys know Osmosis Jones. It's a fantastic show. Sometimes it can be caused by trauma, okay? Especially fish bones, right? They swallowed something and then felt a little funny, didn't really go to go see a doctor or anything, and then a couple days later they come in septic, as well as odontogenic infections. Typically presents with sore throat, dysphagia, lymphadenopathy, as well as trouble breathing. Although I did show a picture of a swollen lymph node there, that was just to show lymphadenopathy, but often visible neck swelling is not common. So if you decide to get imaging, these are the numbers that you should look for in terms of prevertebral space widening. An easier thing to remember is if it is greater than, or if it is greater than half the width of the vertebral body. Less than half the width is considered normal. This X-ray was taken in a child with an RPA at, they were 3 months old. I think it might be a little bit difficult to see, but if you kind of look at where the, where is this? Right here. Okay, nice. So if you just look at, this is the prevertebral space. This is about the width of the vertebral body, which means this is very inflamed. Okay. So this is in an adult. There is free air in there because they had swallowed a fish bone 4 days prior. So assuming the patient is stable, right, you can confirm the diagnosis with a CT neck with contrast, give IV hydration, broad spectrum antibiotics, and call your local ENT. Complications include mediastinal extension of the infection, upper airway asphyxia from direct pressure, or, which I learned from making this presentation, is aspiration after sudden rupture of the abscess. Here is a cross-section CT. So the red is the parapharyngeal abscess, and the blue is the retropharyngeal abscess. What started first? Not really sure, but it's in both spaces now, so it's pretty bad. Here is another view of an RPA. Next thing we're going to talk about is Ludwig's angina. So this is an infection of the submental, sublingual, and submandibular spaces. And so this is just another photo of Ludwig's. Signs and symptoms include poor dental hygiene, dysphagia, odynophagia, trismus, and edema of the entire upper neck and floor of the mouth. It can posteriorly displace the tongue, causing airway compromise. Patients may endorse having tongue swelling, but if you look closer, these patients actually just had floor of the mouth edema, which pushed the tongue posteriorly. So these patients will present with difficulty managing secretions, stridor, and cyanosis, but these are often late signs, okay? You should always remember to consider awake fiber optic intubation or an awake trach, right, which is what they did for our patient. Next pathology is epiglottitis. So for all my sketchy fans, this was traditionally in children. However, incidence of increasing H flu vaccination has reduced this. And so now the mean age that this occurs in is actually patients who are 45 to 54 years old. Typically, there is no causative organism, or it could be caused by H flu, strep, or staph in adults. Risk factors include advanced age and male sex. And these patients present similarly drooling, dysphagia, dysphonia, and dyspnea. But oftentimes, like I said, this is infrequent because a lot of times you may catch this pretty early. You want to remember all your typical signs of a general deep neck space infection: fever, tachycardia, as stridor, trouble breathing. They may have anterior neck tenderness to palpation, as well as cervical lymphadenopathy. You may see an omega-shaped epiglottis yet again on the scope. And on lateral X-ray imaging, you will see the infamous thumbprint sign. You do not need a CT neck to make the diagnosis. And patients who are on antibiotics prior to imaging are at risk for false negative imaging because it will have already started to reduce the epiglottis. So this is a scope of an omega-shaped epiglottis. This was on day 1 of epiglottitis. I included the link and QR code, but the QR code isn't showing. But they continue to show more a progression of this patient's epiglottis. And they show pretty much full resolution of this by, I believe, day 7. But if your ENT sees this or you're looking over their shoulder, you should, be scared, very scared. Let me see. What is this not going? All right, chill out. Give me the next one. Okay. Hold on. Nope, that's the same one. All right. So here's just another image of the thumbprint sign. Now this is a CAT scan that showed. I honestly don't know how they got this patient to CAT scan without a tube, and the patient was alive, and I don't even know if you would call this stable. Just look at the airway. Look at that epiglottis. Like, it's literally just touching the posterior pharyngeal wall. Like, there's no space there. I don't. Anyway, this was taken just from Radiopedia. This is another thumbprint sign. So the last one that we're going to talk about is Lemire syndrome, which is what our patient had. So this typically presents with pharyngeal tonsillitis, as well as internal jugular vein thrombosis. Now, this one shows the a pretty extensive portion of the internal jugular vein is thrombosed here. In our patient, they only discovered it while in the OR, and they showed small branches of thrombosis. Tintinelli says that these patients can present with or without septic emboli, causing metastatic abscesses. Some of the ENT literature says that they need the septic emboli before they will classify this as Lemaire's. But that's just a matter of semantics. Most commonly, this is caused by Fusobacterium necrophorum, and adolescents or young patients, especially smokers, can present with worsening symptoms and neck swelling. So typically, you want to diagnose this using CAT scan with IV contrast, give IV fluids, broad spectrum antibiotics. Consider calling ENT, or definitely call ENT, but they may consider surgical drainage. Sometimes they will also consider anticoagulation, but that is controversial. And in very rare cases, if the patient is throwing a lot of septic emboli, they may consider ligation of the internal jugular vein to prevent further embolization. So for the next part of the presentation, I'm just going to talk about what a device that has traditionally been taught as our rescue or backup device when we're intubating difficult airways, and that is the bougie. So does a bougie improve first pass success? Who here has used a bougie first when intubating? Yeah, not very many of us, right? So this was a study done in 2021. It was a pretty big study that ended up going into JAMA. This was otherwise known as the bougie or stylet in patients undergoing intubation emergently trial, otherwise termed bougie. Yeah, I don't know how they figured that out. Right?
What makes a good study?
So this was a multi-center randomized control trial. Happened in April 2019 to February 21. Involved 7 EDs, 8 ICUs across the country. It's pretty big. This was a pragmatic trial. So what is that? These are designed to provide evidence on real-world clinical interventions. This are focused on diverse patient populations, and these are done by clinicians who actually provide, their typical interventions while practicing every day. Why do we do these? Because they are focused on patient-centered outcomes, and they hope to improve clinical practice, and overall it increases generalizability. These were all the hospitals and facilities that were involved in this study. Some pretty big names, as well as Lincoln, which is right up in the Bronx. Where's Dr. G? Oh no, it's the one day that he's not here. So these were the characteristics of the participants or of the intubators. Okay, what's important here to note is that about 60-ish% were EM, about 35% were crit care, 2% were anesthesia. Some intubators had a combination of specialties. About 60% residents, 34-ish% fellows, so that's pretty sizable number of learners. 2.5% attendings and another 2% as mid-levels. So inclusion criteria included patients in an adult hospital, planned sedation use or unconscious state, and non-hyperangulated laryngoscopic blade. That meant they could either use like CMAC, they could use a glide scope if it had like a MAC blade, like a standard geometry, or they would go DL. Some of them I think also use McGrath, but about 75% ended up going to VL, 25% did DL. Exclusion criteria: if the patients were pregnant or prisoners, if it was too emergent. So the way that the trial was set up, there was an observer who would come in and they would ask the attending, can this patient undergo either a bougie first or an ET tube with the stylet intubation? As long as the attending said yes, and there were no issues with going for one of them, then they could proceed, because then the observer would say, okay, then you're going to do bougie first, or they would say you're going to do stylet. And then they would also be excluded if one or the other was required or contraindicated. So if someone had a difficult airway and the attending said, no, I need to use a bougie for this one, then that patient was excluded from the study. So the study population ended up being about 1,102 patients, median age of 58, 41% women. The bougie group had about 556. The stylet group had about 546. Primary outcome was first attempt intubation success, which meant that it was their first time putting in the blade, and it was their first time putting in either the bougie followed by the ET tube or the ET tube with the stylet. The secondary outcome was any instances where the patient was hypoxic between induction and 2 minutes after intubation. What they were looking at, their goal was to do an intention to treat analysis, which meant they would include everyone in the groups that they were originally assigned. And they were specifically looking at the absolute risk difference between bougie versus stylet. So what does this mean? So the risk of a bad outcome with a bougie minus the risk of a bad outcome with the stylet. What do they find? They found that there was statistically no difference between using a bougie first or using a stylet first. In their secondary outcome, there was also not a significant difference between the rates of hypoxia. And they had a pretty much equivalent number of outcomes of complications. Most commonly were esophageal intubations, injury to the oral, glottic, or thoracic structures, as well as witness aspiration during intubation. So this shows that the first pass success was pretty much equivalent for both. A little bit less in bougie, but again, not statistically significant. But the interesting thing here is that the median duration of first pass success was similar in terms of time as well. So not noted on the graph is that for bougie intubations, it took intubators approximately 124 seconds to intubate. It took intubators 112 seconds using just a regular stylet. So about a 12-second difference for using a bougie versus using a stylet. The one thing that the study didn't indicate was whether these bougies were preloaded with the ET tube, or if someone else, or if they had to then load it after they got the bougie in. Then the researchers did an adjusted analysis based on these indications. So they tried to essentially stratify for if these things made a difference in the findings. These are the difficult airway characteristics that they looked at. You can see that almost half of the patients had one or more difficult airway characteristic. Most commonly was obesity, followed by bodily fluids or blood obscuring your glottis. I go back to this one. This is the intubator characteristics. This part is interesting all the way at the bottom here. So what the bottom shows is that the intubators did not have that much experience using a bougie in general, okay? The median number of prior bougie intubations was 10 for all of the intubators. The median number of previous intubations in general was actually 60. So that's pretty sizable, but at the same time, they didn't give like the actual number of first pass success for specific intubators, just as a overall group for, or like hospital or location. When adjusting for all those other factors that I listed before, the odds ratio is 0.88. So there's still no statistically significant difference between using a bougie first as opposed to just using a stylet. This was a graph that showed when controlling for operator experience as well as for overall intubations versus bougie intubations, still didn't change the primary outcome. And then this was by site. And so by location, the only one site that seems to favor bougie was actually ED site 7 as well as ICU site 5. Overall, people tended to lean a little bit more towards stylet, but again, not statistically significant. So what are the limitations? there was no blinding to technique, obviously, because once the observer told you you had to use either bougie or stylet, you kind of already knew what you were using. They excluded hyperangulated VL. There are a lot of people out there who don't use bougie with hyperangulated blade, but there are also people who do. If you look up Rich Levitan, he has a video on his website that shows you how to use a bougie with a hyperangulated blade. They excluded cases that were too emergent. So sometimes if the observer couldn't get there on time, if they didn't have time to really kind of stratify between the two groups, then they excluded those. So that would mean like cases like a cardiac arrest that rolled in no pre-note or anything, they were excluded because the observer just couldn't get there. And it may not generalize to operators with extensive intubation and bougie experience. So one of the big sites that were included was actually at Hennepin. And at Hennepin, they have a culture of doing bougie first intubations for the last 2 decades. So this may not be generalizable to you if you are, an attending with decades of experience, or you have decades of experience using a bougie as well, right? Because at that point, you have probably mastered the skill and it almost doesn't matter. So overall, does a bougie improve first pass success? No. This is a video of a bougie intubation. So I want you with a complication. So can someone tell me what is going wrong here? One of the juniors. Okay. And so here, we'll replay it. What does the operator do to fix this?
At the end of the ET tube maybe getting caught on the cords or some of the soft tissue there, so he
Correct.
gives it a bit of a turn to essentially,
Correct.
like, release it off of the tissue there.
Yeah, so it's hitting the arytenoids, right? So this is what's happening. The bougie is hitting the arytenoids, and so you have to turn it a little bit counterclockwise so it lifts off of that, and then you can continue passing it. If you take nothing from this lecture, I want you to remember the BLT. All right, this is the bougie left turn. If you're gonna use a bougie, remember if you can't pass it, just turn it 90 degrees to counterclockwise, and you should be able to pass right through. So going back to our case, the rest of the patient's hospital stay, he had multiple INDs back in the OR, had an exploration and washout again at about a month out, had multiple cardiac arrests at about a month and a half, and then eventually expired. So summary, maintain a high index of suspicion for a deep neck space infection if the patient has a constellation of symptoms that include trismus, inflammation below the angle of the mandible, they're drooling, they tell you their voice has changed, they can't swallow, they have trouble breathing, and if they appear septic. Call ENT early. Consider using a bougie more often to add it to your toolbox. And if you do, remember BLT, bougie left turn. Here's all my references.